Hello, my name is Dr. Alexa Lean, and today we'll review safe performance of interlaminar cervical epidural steroid injections. At the fellow level, the focus is not just how to do the procedure, but how to avoid mistakes that cause harm. Our objectives are to understand the cervical epidural anatomy relevant to this procedure, go step by step through the technique using a TUI needle and loss of resistance syringe, review imaging tips, highlight potential complications, and compare alternative techniques. The overarching goal is safety in every step. We'll cover anatomy that directly impacts your needle trajectory, a step-by-step technical approach, imaging strategies to confirm safety, complication prevention and management, alternative techniques, and when to consider them. Again, your goal as a fellow is to understand both how to perform the procedure and when not to perform it. Key structures to keep in mind are the spinal cord, the nerve roots, and the vertebral artery. Most injections are performed at the C7-T1 interlaminar space because the epidural space is widest and safer here. The ligamentum flavum and dura are critical landmarks. Always remember, the spinal cord extends more caudally in the cervical region, so the margin for error is much smaller than in the lumbar spine. The cervical epidural space is shallow. Above C6-7, the margin between the ligamentum flavum, dura, and spinal cord is razor thin. Remember, the spinal cord typically ends at L1-2, but in the cervical region, it's right there. Vertebral arteries course laterally, avoid lateral drift. Perimedian entry can reduce risk of ligament gaps, but the midline approach may be better for fluoroscopic clarity. Before starting, make sure all equipment is ready. TUI needle, loss of resistance syringe, sterile setup, fluoroscopy, contrast, steroid, and local anesthetic. A simple but important safety step: do a standard pre-procedure timeout and confirm your medications, especially non-particulate steroid. Always check positioning and your tray before draping. Confirm steroid type. Agent like dexamethasone is preferred in the cervical spine. Have contrast ready, IV extension tubing, and insist on real-time fluoroscopy. Never inject steroid without confirming contrast spread. Position the patient prone with a slight neck flexion. Apply monitors, pulse oximetry, blood pressure, and EKG. Obtain conformed consent. Clearly review risks such as dural puncture, cord injury, and vascular injection. Skin prep with chlorhexidine pending there are no allergies, then anesthetize with 1% Lido. Again, prone, neck in slight flexion. You can use a pillow under the chest to optimize fluoroscopy. Monitors on, pulse ox, blood pressure. This is not a minor procedure. Treat it like moderate risk anesthesia. Consent is crucial. Emphasize cord injury, vascular injury, and stroke. If the patient doesn't understand those risks, you haven't consented properly. Identify the level with AP and lateral fluoroscopy with most common entry site at C7-T1. Mark your entry, anesthetize at the entry point at midline or perimedian point. Advance the TUI slowly with controlled pressure, never force. Advance under direct fluoro observation. On lateral, the needle tip must not pass the spinolaminar line. If you're anterior to that, you're in danger territory. Stop and redirect. In this video, you will see real-time identification of the entry point and advancing of the TUI in AP as well as lateral imaging. Next, confirm the epidural space with a gentle loss of resistance technique. Avoid aggressive plunger pushes, especially in the cervical spine, where tissue compliance is lower. Always confirm placement with contrast under live fluoroscopy using IV extension. Look for epidural spread and ensure there's no vascular uptake. Finally, inject the steroid slowly, watching for pain, paresthesia, or unexpected responses. Again, the loss of resistance must be gentle. In the cervical spine, the ligamentum flavum is thinner, so tactile feedback can be harder to appreciate. If you're pushing hard, you're probably wrong. Confirm epidural placement with contrast under live fluoroscopy, not just a single shot. Look for that epidural spread. If you see vascular washout, stop. Inject steroids slowly. If the patient has sharp pain, paresthesia, or neurologic change, stop immediately. As depicted in the video, I like to keep my final AP image on the right side as I advance in the lateral using fluoroscopic guidance. AP, lateral, and sometimes oblique views are helpful. The lateral view ensures safe depth. Contrast spread should outline the epidural space. If you see rapid vascular washout, stop immediately. AP shows your alignment. Lateral shows your depth. An epidurogram, by definition, is a lateral image. If you're unsure, the oblique can help, but remember, oblique angles distort depth. Always trust your lateral to avoid cord penetration. Let's review a few safety pearls. Test loss of resistance gently. Loss of resistance may be subtle. Never force air or saline. Avoid midline insertions above C7. The cord is too close. Contrast is your safety net. Never skip it. Always aspirate before injecting. Keep the bevel up to reduce sterile puncture risk and catheterization of a vessel. Last but not least, I recommend reviewing an MRI prior to performing this procedure at the axial view. Let's say you're going to enter at C7T1, go to that level, go to the axial view, and you can actually measure from skin to ligamentum flavum for an idea of depth prior to starting the procedure. Common complications include vasovagal reactions, headache, or temporary pain flare. Serious and catastrophic complications include dural puncture, spinal cord injury, stroke from inadvertent intravascular injection or intramedullary injection. Prevention is the best management. Patient positioning, meticulous fluoroscopy, test dose with live injection of contrast, aspirate, use non-particulate steroids, and inject slower and never under resistance. Remember, these are all elective procedures. Alternative techniques include transforaminal approaches, CT guidance, use of blunt versus sharp needles, and contralateral oblique. Worth mentioning as it can be helpful when a patient's body habitus, like large shoulders, obscure your lateral fluoroscopic image. For safety, many providers prefer non-particulate steroids in the cervical spine. Some advocate for transforaminal or CT-guided approaches. Remember, transforaminal cervical ESIs carry higher vascular risk. At the fellow level, know the pros and cons, but default to the safest interlaminar technique. To recap, respect the anatomy. It's unforgiving. Use fluoroscopy and contrast every time. Loss of resistance should be gentle. Know your complications and how to recognize them early. Patient safety always comes before completing the injection. Thank you for your attention. I encourage everyone to continually refine their technique and to always respect how little room for error exists in the cervical spine. As fellows, your job is not just to learn the mechanics, but to develop the judgment to stop if something feels wrong. Safety comes from vigilance. Thank you.